Onc Live Insights is a video editorial program produced by Onc Live.
The drugs Everolimus or sunitinib have been shown to improve time to progression in patients with metastatic pancreatic neuroendocrine tumors. They're typically used in patients who progress on first-line somatostatin analogs. The choice of everolimus versus sunitinib is often difficult because the results of phase 3 studies have been quite similar. We often look at the side effect profile and have a conversation with the patient about their preference. Most patients with metastatic pancreatic neuroendocrine tumors are candidates for everolimus at some point in their treatment, although there's very little data regarding the appropriate sequencing of patients. I think there's consensus that for most well-differentiated tumors that are not too clinically aggressive, somatostatin analogs are typically the first-line treatment of choice, but choosing between everolimus, sunitinib, chemotherapy, or liver-directed therapy is very difficult, and different oncologists have different patterns and sequences of treatment. I typically use it in patients who are progressing on somatostatin analog but not progressing extremely quickly. Patients with very clinically aggressive tumors, I typically choose chemotherapy. Patients with more indolent disease progression, I often recommend everolimus. The most common toxicity with everolimus is canker sores or aphthous sores of the mouth. I typically use those with, manage those with steroid pastes, although in many cases things like magic mouthwash can be helpful. Pneumonitis is another potential complication of everolimus that can range from fairly mild inflammation and cough to significant cough, dyspnea. And depending on the severity, we either reduce the dose or stop the medication and initiate steroids, or sometimes just take a short treatment break. If we resume everolimus, we often resume at a lower dose. So the starting dose is 10 milligrams daily. Dose reductions can include 7.5 or 5 milligrams daily. Response to treatment can be assessed in various ways. It can be assessed radiographically, can be assessed biochemically through use of tumor markers such as chromogranin A, and it can be assessed clinically in terms of how the patient is feeling on treatment and what is the change in their tumor-related symptoms. The scans, CT scans or MRIs in patients with everolimus rarely show objective tumor response, but on occasion they'll show minor response or stable disease or change sometimes in tumor perfusion characteristics. We'll often continue treatment until there's evidence of objective radiographic progression. In some cases, that may be a very long time until the scans actually show significant tumor growth. Imaging frequency can vary quite a bit in neuroendocrine tumors because they can often be much slower growing than most cancers. In many patients on treatment, we'll obtain CT scans or MRIs every 3 months, but in certain cases every 6 months and rarely even once a year in patients with extremely slow-growing tumors. In the future, increasing use of gallium-68 somatostatin receptor imaging may enhance our ability to assess response to various treatments. Just like any other PET scan, we can look at SUV values to determine response, although it's important to emphasize that this approach has not truly been validated in prospective clinical trials.
In terms of duration of therapy, there's really no cumulative toxicity that we can really see with everolimus. So you can really just continue until evidence of disease progression. Certainly, I have had patients that I have managed and treated for 4 years or 5 years without any problems. Typically, I follow these patients with serial imaging in terms of understanding whether the treatment is continuing to work. I typically repeat anatomic imaging, so CT or MRIs, about every 3 months. And these scans can be continued and while the patient is on treatment.
We learned in 2011 that everolimus is an effective way to treat patients who have advanced pancreatic neuroendocrine tumors. We've also known that there are certainly some similarities between pancreatic neuroendocrine tumors and non-pancreatic neuroendocrine tumors that we often still describe as carcinoid tumors. So there was tremendous interest in looking at whether everolimus might also be effective as a treatment for non-pancreatic neuroendocrine tumors or carcinoid tumors. Very recently, some exciting results came out from the RADIANT-4 study. This was a study in which patients with advanced carcinoid tumors, whether they were in the GI tract or in the lung, were randomized to receive treatment with either everolimus or placebo. And that study showed that treatment with everolimus was associated with a significant improvement in progression-free survival. I think everolimus can now be used not just in pancreatic neuroendocrine tumors, but also in other types of neuroendocrine tumors. I think RADIANT-4 quite definitively showed that everolimus is an effective treatment for carcinoid tumors that start in the GI tract or carcinoid tumors that start in the lung.